The Transperitoneal Laparoscopic Adrenalectomy by Mario Zacharias and co-workers. We will first demonstrate the OR setup showing the surgeon and assistant position as well as those of the scrub nurse, the instrument tables and the monitors. In a left-sided adrenalectomy shown in this video, the surgeon and first assistant are standing on the right side of the patient, whereas the second assistant and the scrub nurse are on its left side. The instrument table is placed at the foot and one or two monitors at the head of the patient. This setup provides excellent vision for all involved. Four trocars are required to safely perform this operation. With the patient in the 0-degree position, the first trocar, the gamma trocar port, is placed in the supraumbilical region. The further ports are positioned in the subxiphoidal region 2 cm below the xiphoid and in the medioclavicular line 2 respectively 10 cm below the subcostal margin. The three ports are positioned under visual control through the 0-degree laparoscope. These trocars are going to be placed with the patient in the 60-degree elevated position, the affected side elevated above. For the entire procedure, the patient is placed in the 60-degree elevated position, the affected side up. The ipsilateral arm is lifted in a hanger, whereas the contralateral arm is padded, closed and extended to the body of the patient. Demonstrate the insertion of the last trocar under visual control. This trocar, which can be seen on the video, is the subxiphoidal trocar, seen on the left side, whereas the upper trocar is the pararectal one. After all trocars are placed, the spleen and the left colonic flexure are well visualized as illustrated in this image. We identify and insert the line of told cranially as high as the splenic flexure and caudally as far low as to the sigmoid junction. The medialization of the left colonic flexure follows. The colon is mobilized medially to expose the upper pole of the kidney and Gerota's fascia. Again, monopolar scissors and atraumatic graspers are the instruments of choice. The incision of the splenocoelic ligament is crucial to provide adequate medialization of the left colonic flexure. This medialization has to be done completely to provide adequate exposure to the upper pole of the kidney. Once this is done, the upper pole of the kidney is accessible. Great care has to be taken not to cause injury to the pancreas, which is located very close below the splenocoelic ligament. This is illustrated in the following anatomic outline. We now incise Gerota's fascia to expose the renal hilum. Once Gerota's fascia is incised, it is elevated with the atraumatic grasper. Thus, pancreas and spleen are moved out of the OR field. The fan retractor is inserted through the subxiphoid trocar to further aid in medialization of the left colonic flexure. We now access the renal and adrenal vein. This sketch outlines the main anatomic structures. The renal vein, in which the main adrenal vein enters, is located in the lower right part of this image. The periadrenal fat, in which the adrenal gland is hidden, can be seen left and cranially to that. The spleen is in the upper right part of the image. The renal vein marks the lower boundary of resection and the main adrenal vein has to be fully exposed to at least 5 mm to guarantee safe positioning of clips. Now all fatty tissue around the renal vein is mobilized and incised to expose the main adrenal vein. Occasional careful blunt dissection may be helpful in this part of the procedure. Great care has to be taken to identify adrenal veins as early as possible. In this case, an accessory adrenal vein is clipped and divided. 5 mm titanium clips, 2 proximal and 1 distal of each vessel are to be used. Using an endopeanut, the renal vein is further isolated. The main adrenal vein is now identified, clipped and divided. It is advisable to apply again 2 clips proximally and 1 clip distally. Likewise, we recommend that before the vein is divided completely and after the clips have been placed, to just incise it partially to verify if the clips hold the vein completely close. Only thereafter the vein should be divided completely, as you can see right now. The renal vein and periadrenal tissue are cranially now completely separated. We now begin the mobilization of the adrenal gland dorsally to the renal vein. This anatomic sketch outlines the main structures. We are now introducing the bipolar dissector instead of the monopolar scissors. Using this bipolar dissector, small vessels hidden in periadrenal tissue can be coagulated and safely divided. It is useful to use the stump of the adrenal vein to elevate the adrenal gland itself. Thus, the adrenal gland can be continuously separated from adjacent tissue. We now expose the dorsal surface of the adrenal gland. This anatomic outline shows the main structures to be considered during this part of the operation. The bipolar dissector is used to coagulate and divide the superior suprarenal arteries. Note the pulsation of the aorta in the lower left part of the image. Subsequently, the cranial dissection of the adrenal gland is performed. The anatomic structures are shown in this image. The spleen is carefully lifted cranially, and the dividing layer between the spleen and the upper surface of the adrenal gland is identified and separated. Further separation of the periadrenal tissue and the upper pole of the kidney is done using the bipolar dissector. Once the separation of the adrenal gland from the upper pole of the kidney is essentially complete, an endo-Babcock clamp is introduced. Using this endo-Babcock clamp, the adrenal gland is pulled cranially to further separate it from the upper pole of the kidney. The endo-Babcock clamp is repositioned to improve the access to the most lateral boundaries of the dissection. Using the endo-Babcock clamp, the spleen is now carefully pushed cranially to expose the most cranial and dorsal aspects of the adrenal gland, reaching down towards the psoas muscle. The final strands of connective tissue between the adrenal gland and adjacent structures are divided and coagulated to fully liberate the adrenal gland. Careful hemostasis follows. Finally, the adrenal gland is maneuvered into the endocaudal bag and excreted through the supraumbilical camera port incision